Well, I will present another case, and this case also summarizes some of the points that Dave was presenting in the previous ones. Apologies because I forgot to include a conflicts of interest slide, but I can summarize it saying that I have been working with almost all companies that had any products on COPD. And this is the case. So this is a lady. When she first came to see me, she was, when she first came to see me, she was 10 years ago. She was 67. Now she's a 77 years old woman. She smoked until 10 years ago, a total of 45 pack years. She had frequent respiratory infections during youth, but no signs of allergy and no previous diagnosis of asthma. Apparently, they were episodes described as bronchitis. And she was diagnosed with COPD some 15 years ago, and she was treated in another hospital with triple therapy. She was given, at that time, there were not fixed dose combinations with tiotropium and fluticasone and salmeterol 550 twice a day. And 10 years ago, she was admitted for a first episode of pneumonia. And at that time is when she was really scared and she finally quit smoking. So it's a lady, heavy smoker with COPD, frequent infections over many years and treated with triple therapy. When she came, she referred 2-3 exacerbations a year that require short courses of antibiotics and oral corticosteroids. The sputum culture also grew different bacteria, but during the last couple of years, systematically, we isolated the Pseudomonas aeruginosa were resistant to quinolones with multi-drug resistant Pseudomonas. And we performed a CT scan with severe emphysema and cylindrical B-basal bronchiectasis. And the immunologic tests were normal, including IgG subclasses. And we stimulate also with different vaccines to see antibody response, and all immunological studies were negative. I brought some images from the CT scan, so you can see the centrilobular emphysema in the upper lobes. And then this small cylindrical bilateral bronchiectasis, not spectacular. These are not the type of bronchiectasis you will see in a cystic fibrosis or post-tuberculosis, for example. These are small cylindrical bronchiectasis, bilateral, and also combined with this diffuse emphysema. So this is the spirometry. She had a severe COPD with an FEV1 predicted of 37%. She was a thin lady with a low body mass index with an emphysematous phenotype. And this is, so she was referred to me because the previous treating physician thought that she would require inhaled anti-pseudomonal antibiotics. But then before that, I would like to make a question. In this case, would you first discontinue ICS? I don't know if you would like to make some comments, or do you want me to answer first?
So Mark, I think I would probably cut down the dose of ICS here, but Dave, what would you do?
Yeah, so it's an interesting case, and there are some similarities to the one I presented. And in the one I presented, I just continued with the ICS, but I think Mark's presenting something that's real, that inhaled corticosteroids are associated with pneumonia. They are associated with more bacterial colonization. So there is a good case to either temporarily discontinue or give the absolute minimum dose. Now, coming back to the dose discussion though, sometimes if you give a lower dose, you're missing some of the therapeutic benefit. So I think this might go in stages where you might have to temporarily discontinue deal with the bacterial problems. There's different. I don't think there's a wrong and right here. But as long as people are aware of the issues.
Yeah, well, this happened with the first visit, so it was some 10 years ago. And at that time, due to the repeated isolation of Pseudomonas, the recurrent infections, the previous pneumonia, she also had capillary frailty due to the use of steroids, both inhaled and courses of oral steroids. We decided to withdraw steroids, and then we put the lady on 2 bronchodilators, mucolytic and acetylcysteine 600 milligrams twice a day, and azithromycin 3 days per week, Monday, Wednesday, and Friday, at doses of 250 because this lady had a very low body weight. Well, this was the change in therapy.
Sorry, Mark, to interrupt you, but I noticed Dave also put his patient on long-term azithromycin. Are you all concerned? I mean, Dave's patient was quite old, the first patient, right? Would you be worried about hearing issues, or have you all good experience with more than 1 year now of azithromycin without too much side effects, Mark?
In fact, we do. I mean, we have a very good experience. We have, I don't have dozens of patients on long-term azithromycin. I may have approximately 8 to 10. And my experience is very good. I mean, we always perform an electrocardiogram, liver enzymes, and also we ask the patient to be aware if they have any hearing problems. And I must say that we do not have patients on very long time continuous azithromycin treatment. So we give this treatment for a period of 1 year. If this is successful, then we prolong it for another year. But then what we do without any evidence is we treat these patients in winter periods, in 6 months periods, and then we stop another 6 months. And because most of the exacerbation occurred during winters. And in fact, the patients know very well, and they start from Halloween to the 1st of May. So to the 1st of November to the 1st of May. It's exactly 6 months, and with very good results and very low occurrence of significant side effects. Right, then in the evolution, I mean, at 3 months control, the patient had no exacerbations, and the sputum production was reduced in the patient. However, she felt an increase in dyspnea and wheezing. And in fact, she was concerned that by the discontinuation of ICS may have some role on that. So then the question we had to face is if we should reintroduce ICS, because the patient, if this is a failure of the discontinuation of ICS or just has no relation at all with this.
Okay, Mark. So is there any study on that, Mark? And when I mean that, I mean any study on reintroduction of steroids after they've been withdrawn?
Yeah, there are discontinuation trials, and the discontinuation trials in general, they show that there is not an increased risk of exacerbation except in patients with high eosinophil counts, but they also consistently show a reduction in FEV1. A reduction in FEV1 that again is higher in patients with high eosinophil counts. So then there is one piece of information that I did not present before, is that this patient had 420 eosinophils in peripheral blood, 6% count. And therefore, we reintroduced. So this happens almost 10 years ago when we did not have so much information about the role of eosinophils. And we made the decision to discontinue ICS exclusively based on clinical grounds, but not on eosinophil counts. But then when I went back to the story of this lady after so many years, I went back to the initial blood eosinophil counts, and they were high. So I think that the exacerbations in this lady were basically due to infection, and they were well controlled with the addition of azithromycin, high-dose mucolytics, And even perhaps the discontinuation of ICS may have some impact in improving host defenses against the infection. But on the other hand, probably this lady suffered from a reduction in lung function, because with this level of blood eosinophils, she was at risk of having a significant decline in FEV1, and therefore more dyspnea as she was experiencing. So we decided to restart ICS again, but instead of restarting fluticasone at high doses as she was taking, we reintroduced budesonide 200 twice a day. And then the scheme of treatment was triple therapy, but with low dose of budesonide. And she had a very good control of symptoms. The dyspnea returned to baseline. There were no significant exacerbations. And we continue with N-acetylcysteine twice a day and azithromycin. And the spirometry did not change over the course of the years, and she was stable with minor and infrequent exacerbations under this regime. So this, in this case, this is a story of what we could call a failure in the discontinuation of ICS. This is a lady that, from a clinical point of view, there were reasons to think that ICS could be responsible for some significant side effects, and I think it was justified to try to discontinue. But then if we had known what we know today about blood eosinophils, probably we would not have made that decision, because with 420 eosinophils, it's very likely that discontinuation of ICS may result in some effects. And in fact, in this lady, it was translated not in an increase of exacerbation, but it was translated into an increase of dyspnea, probably caused by a decrease in FEV1. We did not perform a spirometry at that time, so I cannot verify that. But when we reintroduce ICS, even at lower doses, this dyspnea disappeared. So in this case, we continue treatment for the chronic bronchial infection, as in the first case that they presented, and we continue with ICS, but in this case at lower dose. And here there is this discussion: is this enough? I think it is from the point of view of controlling symptoms and controlling exacerbations, but we do not know about the possible effects on survival. So this patient has been quite clinically stable, and also from a lung function point of view, but this is always the doubt if we should increase the dose of inhaled steroids in order to this possible effect on increasing survival with a high dose of budesonide compared to low dose.
Okay, so Mark, that brings us to this question of which steroid would you use, and fluticasone has received a lot of bad press in recent years because of side effects. I personally prefer budesonide, and we have ciclesonide also available in India now. I don't know about Spain and the UK's availability and what your preferences are. Can you tell us?
Yeah, ciclesonide is available, but is not licensed for COPD. So the use of in COPD is off-label, although I know that there are some patients with COPD that are treated with ciclesonide, but the use is restricted by this off-label use. But I think it could be potentially also an alternative. But you're right. I mean, fluticasone has been thought to have a higher risk, particularly of pneumonia, but not only pneumonia, also perhaps in osteoporosis and bone fractures. There are some studies that suggest that there is an increased risk, probably also related to the doses, because usually fluticasone is used at higher doses than budesonide. Probably this is a dose-related side effect.
Can I come in here?
Yes.
So when we talk about side effects, I think we just have to be very careful about comparing across studies. So people are focused a lot on pneumonia, And there's a well-known set of risk factors for pneumonia, and it's many of those risk factors are to do with more severe disease, getting older, being frailer. So there's an at-risk group, and so when you look at clinical trials, studies that recruit these at-risk groups have higher pneumonia incidence, and that's all of a sudden then where you start to see the effect of ICS on pneumonia. So let me just give you an example. We're talking about fluticasone. Obviously there's two fluticasone compounds, there's propionate and furoate, and furate's in the current triple. If you look at this SUMMIT study with fluticasone furate, there are very few pneumonia episodes, and the ICS doesn't appear to cause pneumonia. Now, why is that? It's because all the patients had an FEV1 above 50%, they were younger patients, there were few exacerbations, so they're not the high risk group. So then when you go and look in the IMPACT study, where the patients are sicker with lower lung function, you suddenly get a higher pneumonia rate with the same steroid. And so what I disagree with is when people look across studies and say steroid A causes more or less pneumonia than steroid B. You can't do it, the populations are different.
So I guess it'll all boil down to personal preferences and choices that respiratory physicians have.